Welcome to today's episode of the Back in Shape podcast. Today we're going to be covering the best and worst exercises for a herniated disc. So if you're someone who's got a lower back injury, you've been diagnosed with a herniated disc, whether it's actually herniated or you've got a bulging, slip disc, or there's even some degenerative disc disease there, this is going to be really, really helpful for you. We're going to be covering, first and foremost, a little bit about the discs, how they herniate, etc., because that's important to understand, because so often people don't understand why they're being given certain exercises. And hopefully if there's one thing this podcast episode is really going to do, and the associated article that goes into tons of detail, is help you understand why have you been recommended X, Y, or Z. And that's going to help you kind of formulate how that fits into maybe a short-term strategy, which might be often short-sighted, or other exercises that actually fit into a long-term strategy and are really helping you fundamentally heal that herniated disc. So it really explains why we are against some of these exercises, and hopefully gives you that explanation. So for once and for all, you can kind of get past all of that misinformation or conflicting information, perhaps is a better word, conflicting information that's out there. So remember, people that have recommended you some of these exercises, they are really, really common. The NHS website, you go to a physio, osteo, even a chiro, you're going to probably be recommended some of these. But hopefully by the end of this podcast, you'll really understand why you're recommended those exercises and what they're actually doing for your back. So as always with these podcasts, if there's any questions you've got, then please do post those in the comment section, and we'll kind of go through those, and we read and reply to all of your comments, and they help give you that extra clarification, and also they help guide the episodes of the podcast going forward. So with that out of the way, let's start off by talking just very briefly about a sort of an overview of discs, because quite often people get stuck on back pain, they get stuck on sciatica pain, and sometimes you've got that disc injury, that herniated disc, and you don't have any leg pain. So you hear someone like us, for example, talking about herniated discs and talking about back pain, and you think, oh, well, that doesn't apply to me because I've got sciatica and my symptoms are only in my leg. And it's helpful when you hear the word back pain, when you hear the word sciatica, think back injury. And for the duration of this episode and many of our other episodes, think of back injury in your mind. It doesn't really matter whether it is an L5 disc bulge that causes you to have specific back pain on the left-hand side, the right-hand side, or someone else who has sciatic pain down the leg and doesn't have any lower back symptoms to speak of. You both have that L5S1 disc herniation, and what we're talking about in today's episode applies to both of you. So that's one of the really important things. It's a back injury that we're talking about today, and that is obviously going to be that herniated disc. And know that it's good to think of herniated discs really as a spectrum, and think of them as really a disc strain. It could be that it's just strained, it's been damaged a little bit, or it could be that it's bulging or slipped, as the terminology could be. It could be that we've got a full-on herniation, it's blowing out, and the disc material from the inside has come out completely. Or it could be that there's some element of degenerative change in the disc. The discs are dehydrated. We did an episode relatively recently on degenerative disc disease, and we spoke all about that as well. And what we're talking about today are exercises that will be recommended to all of those. Often herniated disc is a kind of catch-all diagnosis that just talks about a bad disc injury in many cases, for the patient anyway. And so any number of these exercises could probably have been recommended to you to do. And there will be others as well. But from a principle point of view, many of the other exercises that maybe we haven't covered here, and we've covered quite a few, will be replicated in the principles and the critique that goes alongside those. So that's really important. Now let's talk about the structure of the disc itself. And this is the same for all the spinal discs. The discs really, they run between the vertebral body. Now, the vertebral body is the large part of the disc, of the vertebral unit, sorry. It's the front part, and we've got the vertebral body on top, then we've got a disc, and then we've got a vertebral body underneath. And that disc acts as a cushion. It acts to allow for movement. It also acts as a spacer on the back part where those little nerves come out. Now, in the lower lumbar spine, those nerves come out, they go down into the leg. They might form the femoral nerve, which goes down to supply your quads. They might form the sciatic nerve, which many of you will be familiar with, perhaps not have a very good relationship with that familiarity, but that goes on to form the sciatic nerve and goes down the leg, hamstrings, calves, etc. That's where you're going to get sort of the nerve supply going from the sciatic nerve. But the discs acts as a large spacer. And importantly, we separate them out for anatomical reasons when we're talking about them, but they function so similarly. As we go through the vertebra from the front part of the disc all the way through to the back part of the disc, and then the ligaments that are on the back section of the vertebral unit itself, the ligaments on the very, very back part where sort of the spinous processes stick out, the kind of the bony bits, we've got the ligaments between there as well. They all function together. And they function to provide a degree of tension through the entirety of your spine. So all of those segments through the spine move as one. They bend forwards, they bend sideways, they bend backwards, they deal with load. They all work together as a system that is, to a certain degree, relatively stiff, so that no one segment bears too much of the compression or of the twisting or bending movement compared to any of the others. It allows sort of the equal distribution of load and stress and strain through the entirety of the spine. And if we drill down to the individual structure, the disc itself, often there's that analogy of a jam donut. And what we have on the outer layers of the disc, and this is the majority of the disc, although we say outer layer, we think, oh, maybe it's the outer bit. It's actually quite a lot of the disc. We have somewhere between 7 and 15, something like that, layers of ligament, and these make up the annulus fibrosis. And these ligaments aren't running straight down, they're running at angles to one another, so they create this mesh, and some of them, as we rotate one way, some of the fibers or every other fiber is going to come onto tension and take more load. As we rotate the other way, other fibers are going to take more load because they get stretched and pulled. Some are going to be taken off slack, and this is an intelligent design to create an incredibly strong structure to one-off movements in different directions, and we have to have that in our mind. Some people, unfortunately, when they have back injuries, they feel, oh, I've got a glass back, my back's so very vulnerable. And that's just because we haven't rehabbed it properly. We haven't built strength there. The body will adapt to the stress and strain you put on it. And sometimes if we have an injury, we struggle to come back from that. It doesn't mean that our back needs to be weak for the long term, but at that moment, we do have a weakness, which we'll get onto in a moment. So then we've got the annulus, which kind of holds in the nucleus, and this is the jam of the donut. And it is a watery, fluidy, stroke gel-like structure that is really designed to be non-compressible. Fluid is non-compressible, so we've got this gel in the middle, and as we squash down, we bear load, the force of the vertebra squashing onto one another causes the gel to want to move out to the side. And then there is the strong ligament layers that we've just discussed from the annulus fibrosis, which bulge a little bit. Normally, they stretch, they give a little bit, just like when they bend one way, these stretch and these compress, etc. And it gives a little bit to create this shock absorption. And that's how it should work. Now, when we get, which moves on to the next part of the herniation, what is happening here? This creates a weak point. Now, instead of the annulus completely, all of those 7, 15 layers holding that in place, holding the fluid in place so it can function, it starts to break through some of these layers. Now, I won't get too much into the neurology here, but many of those internal layers, the ones closest to the nucleus, we don't have a very good awareness for what's going on there. And this is why these injuries creep up. The nucleus will have broken through a number of those layers long before you even feel any pain. So you're already weak before you knew it, if that makes sense. And that's what can often make people think, well, why have I got, it only came on the last 6 weeks, but actually it's been building for many years, unfortunately, slowly weakening the layers that support the fundamental structure of that disc. And then we have the full-blown herniation where it starts to creep out into the layers that we can feel, and we have the pain. We have the inflammation, etc. But in that moment that the disc or the central disc material has started to herniate through the layers of the annulus fibrosis, through the layers of ligament material holding it in place, that whole structure is now compromised. When we squash, it breaks through some of those layers. When we bend one way or other, it pulls those layers which have ripped apart, it strains them in a way that is not helpful. And more importantly, remember how I mentioned earlier, the whole spine, all these structures require that smooth and equal tension throughout all of them as they move in any one direction. All the others are really strong still, or many of them will be really strong. Now, when you do any of these normal movements, instead of movement flowing through equally through all of the spine, it's going to go for that weakest spot. In the article I wrote, it's kind of like in Africa, you're looking at a pride of lions. They go after the weak wildebeest as they're trying to hunt. They want to take that weak one out because it's going to be an easy kill, and then they can sort of feed the pride. Well, it's the same thing with movement. It's going to focus and take out the weakest point. It's going to leak out of that weakest point where you have the injury. And that is something that is such a challenge for people, because fundamentally, once you've got that weak spot, we can't control where we move, which joints we move. I can bend my elbow without moving my wrist, and I can bend my elbow without moving my shoulder, but I can't move L5 or hold L5 still while I move L4, 3, 2, 1. I can't do that because I'm not wired to do that. And that's where things get exploited once we have the injury. And there's two additional things that make this even worse, is that often when we're dealing, well, not often, always, when we're dealing with a back injury, it would be really good if that back injury, that disc injury, that herniated disc, was in the elbow, was in the knee, was in the foot. Why? Because there's plenty of space. We've injured a ligament in our ankle before. We see the ankle balloons, it swells up loads. And knowing that the disc is ligamentous in nature, or most of it, or a significant portion of it, the same sort of structures will happen, sort of reactions will happen. Inflammation will build up. Inflammation is necessary for the healing process. It's important. And in the ankle, we've got plenty of space for that to swell. But in the spine, we have those bony tubes through which the nerves run that go down to the sciatic nerve. And those are finite in space. There is no extra room in there. And there's only one thing we can do to increase the room in those, and that's bend forwards. But what does bending forwards do? As we bend forwards, we press down on the front of that donut, and that drives the disc material that's in there, that fluid that's non-compressible, further back into those weakened layers and creates more aggravation. Now, there's two complications that come with these herniated discs, and this can make things difficult and make us lean into wanting to do the wrong sorts of movements. And the first one of those is going to be the fact that the disc often bulges into that space and makes the space smaller straight out the gate. The second point is that there's inflammation in that space, which builds up, creates, and I say, I've said it many times before on the podcast, if you're a regular watcher, I apologize for repeating this again, but it's like having a lift that's supposed to take 10 people and you start cramming 12, 13, 14 people in. What do you want to do? You want to make the lift bigger, but you can't in many cases. So what do? We bend forwards, and that is what allows us to artificially make that lift bigger. But as I mentioned a moment ago, it creates problems. It creates aggravation. It creates worsening of symptoms, even if in the moment it feels nice. If you could imagine making that lift immediately a few people bigger, then all of a sudden the people that were squashed in there and uncomfortable, they'd immediately relax. But then all of a sudden you have to deal with the consequences of that. So that's one of I suppose that's hopefully a good, and you've got a good understanding now of some of the basic premises, the basic principles around the disc structure, how it herniates, why that's a problem, and start thinking about the integrity of those structures and what is actually happening when we have that herniation. And these ligaments on the back part of the disc, the back part of the annulus, have been damaged, frayed. That's what causes them to start bulging. That the load of gravity now is squeezing the disc material backwards into that area. And the more we aggravate that process, the more it interferes with that process. And before we get into the exercises specifically and the stretches, etc., just one final example, which hopefully will hit home in the first exercises that we go through. If you'd sprained your wrist and it kind of cocked off to the side like that, and we've strained all these ligaments, the last thing you would do as part of your therapy would be bending it more like that. Or the same thing, I used the example in the article of the ankle. You're just straining. We wouldn't want to continue straining and pulling on those damaged ligaments straight out the gate. That would be unwise. Yet so many times, even on the NHS guidance here in the UK, as I mentioned earlier, many healthcare practitioners will recommend stretching those things that have been injured right out the gate. And we can see, hopefully even now, why they're going to be a problem. So I've got a couple of notes on the board, so I want to make sure I cover all of them. I'm going to kind of cover very briefly the sort of the categories and the stretches, and then we'll kind of go into the critique a little bit of each one. So hopefully you can understand that a little bit more. I'm not going to go through how to do the exercises. We've got that in the article. So if you're particularly interested, you can go and read that. But really what I want with this podcast is to help you guys understand the critique of these, what they're doing or supposed to do, and why that maybe is going to be good or maybe is going to be bad. So first of all, we've got the stretches. We've got the knee hug, we've got the child pose, and we've got the piriformis stretch. All of these, if we take the first two, the knee hug and the child's pose, fundamentally, these are addressing the space issue. They're addressing the fact that the space gets occupied. That leads to aggravation in the area, a feeling of pressure building up, a feeling of tension building up. Often then we get a reactionary muscle spasm associated with that, as that little hole, those little holes behind where the disc is herniated start to get filled with inflammation, and we want to make them larger. So we get into these sorts of exercises which pull forwards, opening that hole and allow us to get a little bit of respite. But what is that doing at the same time? As we do those movements, as we've covered in the dedicated podcast on child's pose, in fact, is we're pulling open those areas that have been damaged. We're pressing down on the front part of the discs by virtue of moving it into flexion, or moving the vertebral unit into flexion. That presses down on the front. It stretches the ligaments on the back, which are trying to tighten back up again. If you look at any wound on the surface of your skin, you can see very clearly what happens during the healing process is the two sides try to knit back together again. And if your practice involves pulling them apart multiple times a day because you're told to do it for relief, you find that you need to do it more and more and more, and people find it gets less and less and less relief. And this fundamentally is not doing anything to improve your status quo, for example. And what I mean by that is other exercises, which we'll get to later, which are better, are actually building something. But the knee hug stretch, the child's pose stretch, and the piriformis stretch as well, those aren't really doing anything that accumulates over time in terms of doing it. Strengthening exercises, on the other hand, do start to build something so that in 6 weeks' time, especially if you're doing them correctly, because you can still do strengthening exercises incorrectly, which we'll get onto later, in 6 weeks' time, you're stronger. You actually have improved in some manner. But with these stretches, they're just practices. And there's a time and a place for a practice, but it has to be the right practice that's fundamentally helping the healing process. And clearly, these are not. They are replicating the very action that many of you watching this have done when you, quote unquote, injured your lower back or the final straw. Bending down to put the socks on, leaning over to put the shopping in the boot of the car, whatever it may be. Insert activity here, but chances are it involves some degree of forward bending or compression or a mixture of both, maybe with some twisting, all exposing those same areas that the child's pose and the knee hugs are going to expose. When we talk about the piriformis stretch, unfortunately, this is commonly done with a rounded lower back, and you're pulling the knee towards your chest with the leg kind of cocked over the other in that figure four position. So it kind of has the effect of kind of being a knee hug stretch. So that's not good. You could potentially do it without doing the knee hug, but then again, you're starting to work on a muscle that's kind of really overrated in many ways. The piriformis, just like the hamstring group, just like the glute group, just like the calves, just like any other of the muscles that are controlled by an injury in your by the segments of the lower back that are commonly injured, L5S1, L45, those muscles are going to go tight because there is an injury there. Spending excessive time focusing on for months on end, trying to do these figure four stretches, assuming you're not doing them in a way that is counterproductive from a point of view of hugging the knees and those sorts of mechanisms, assuming you do it perfectly, which most people don't, they just pull as hard as they can and flatten the lower back, it's of limited value because it's not really working on a significant part of the problem fundamentally. It's working on some muscle that's tight, and as soon as you go and walk around the house, you flare your back up again, the signals go straight back to that muscle until it's tightened back up again. So it's of limited utility in that regard, and often is done in a way that causes more aggravation. So let's get on to the movements. And movements are different. They're very similar to stretches in so much as they have a very limited window of effectiveness. Now, it's worth just going back and saying we do advocate certain stretching, the right sort of stretching, that stretching of the hip musculature, like the piriformis, but it's better to be more general, to work on the glutes in general, to work on the hamstrings in general, to work on the hip flexors in general, in a way that doesn't involve the lower back. That's very, very important. That must be done. But knowing that in the early days of recovering from a herniated disc, although that helps, that's not a major part of the recovery process. There's other things that are more important. And targeting such a small muscle, one of 6 lateral hip rotators, a tiny one that you probably can't even point to, even though you might think you're pointing at it. You're pointing on the glute, you're pointing through the glute, the glute max. Maybe you're pressing onto glute medius as well. And you're just you're not able to be specific enough to that tiny little muscle, and to suggest that such a small muscle is the be all and end all of your back pain is something that I think is misguided. And we talk about that in detail on the specific podcast on piriformis syndrome, which we link to in the article, in fact. So when we get on to movements, these are non-cumulative. A great one, the couple that we've got here on the board today are the cat-cow, the pelvic tuck, knee rocking, and the cobra. Now, the cobra is an interesting one, but I'll cover the cat-cow first and foremost, as well as the pelvic tuck to a degree, because these, again, the cat-cow very much has got remnants of that knee hug movement. We're moving the back into extension and then into flexion, extension into flexion. Just doing the same movement over and over again is not cumulatively beneficial. It doesn't help lead to any sustained benefits. You're not working anything out. You have a degree of instability in there. We have to remember, when we injure our back and we have that disc herniation, we have fundamentally interfered with the structures that maintain integrity of that section. Once the ligaments and the tissues that maintain the integrity start to heal again, then the thing will move properly. But until that time, and this is one of the reasons that the Cobra is such a challenge, that segment will be unstable. It will shear rather than bend and pivot like the other segments will. It will not move appropriately in its little confined space. So just wiggling and moving in different directions in a way that is non-specific, because we can't be specific to a specific segment, is not going to be helpful in the long term. We're just doing something over and over again, which is very difficult to say whether it's actually helpful or not. And that's gleaned out of the fact that, or that's directed by the fact that, oh, we feel stiff, so we should move. That's not always the case. What do we do if we have a broken limb, for example? We put it in cast so it can set, so healing can start to take place. That's in a bone. Bones heal really, really fast. They really do. They have very good blood supply. The discs, on the other hand, don't. And they're bombarded by load bearing every day because we have to live in the real world. So we have to be smart about the way in which we do these sorts of things. So let me get on to pelvic tuck. Pelvic tuck is a really common one. It's taught with yoga, it's taught in Pilates. Do your pelvic tuck, help you engage, etc. Sometimes it's done as a movement in of itself. Tuck the pelvis, untuck it. Tuck the pelvis, untuck it. Other times it's done tuck your pelvis and then do a bridge, as we'll get onto later on. This is an inappropriate exercise, primarily because if you're learning how to engage your core, which is important for later on, if you're always hooking that to a posterior pelvic tuck, you're always hooking a movement to an elimination of the lumbar curve, a flaring out and disengagement of the sacroiliac joints, and that's relatively speaking, that's not massively, but it relatively disengages the sacroiliac joints when we tuck our bum under, essentially. And it's not useful. We want to practice getting into a neutral position and maintaining a neutral lumbar spine and a neutral lordosis with core engagement, not inadvertently hooking ourselves into a pattern of movement that is going to be pathological when we're standing up and when we're load bearing, which we must do later on in order to rebuild resilience. So that's one that's just not helpful, not to mention the fact that, again, it's focusing that forward bending movement straight into that lower back, just like the movements that we mentioned earlier, cat-cow, and child's pose, and the knee hugs. Then we get into the knee rocks. Now, these, again, think about what's happened here. We've got an injury to the lower back, and we have a degree of instability at that segment. As we're rocking our knees from left to right, we could make the statement that actually this is probably not so risky in terms of aggravating the healing process per se, but because the segment is going to have a degree of instability to it as a result of this, we're going to often find that that's the sort of exercise that can result in the facets banging into one another, in a very sort of colloquial term. They're banging into one another and we get a bit of sharp local pain. Now, in the grand scheme of things, that's not going to be significant, but it'll feel pretty significant when it happens. And for what purpose? Why are we trying to wiggle it? Just for the sake of wiggling it? It's not helpful when we need to really provide stability to the injured region. And then we can add in mobility much later on, as is appropriate, based on a number of criteria later on in the recovery process, but far later on, rather than right now. Right now, while it's injured, you need to provide stability, because too many of us that injure our lower backs over the years, granted, if you're a power lifter watching this, if you're an elite level athlete, there's a different kettle of fish for you guys, because you're probably extremely conditioned watching this. You're in a very good physical condition, and some of these things maybe don't apply to you, but the average mere mortals among us, this does apply to. We're not strong enough. The average person spends 9.5 hours a day sitting down. That's not appropriate. You will not have the appropriate strength and stability, and that needs to come first, rather than these sorts of exercises that just make you more wobbly. And ironically, they're given as easy exercises to people that are perhaps a little bit older, maybe a little bit less steady on their feet, maybe a little bit, just less athletic perhaps in the certain stage of life that they're in. Yet those are the people that can least afford not to build strength and can least afford to accommodate more instability. So something worth thinking about. Now that brings me to the last one, which is going to be the Cobra. Cobra is an interesting one because it is actually the first one that starts to acknowledge the appropriate direction that we want to go in, which is taking pressure off the discs rather than squashing down on them more. However, it's one of those ones where, because it's not maintaining neutral in the spine and it's actually getting extension in. Extension is the exact opposite of flexion, and that's going to make those holes smaller. So if you do have a bit of disc bulging into the back part of the spine of the exit foramina where the nerves come out of, the Cobra can be one of those ones that really aggravates people and creates a bit of irritation. Because of the movement, it's just an extension compression motion. There's no stretch through the Cobra. It is just bending backwards. And yes, we stretch the rectus abdominis muscles, but it doesn't put an elongating stretch through the spine like we'll get onto later on with some of the recommendations. So it is a difficult one. And additionally, those with L5S1 issues where we have that instability, it's very common that we get that shearing motion taking place as the person goes back into extension. And that's often something that aggravates people, particularly when we look at the presence of retrolisthesis, which is a backward shifting of the vertebra on top of the sacrum. This is L5S1, where it shears backwards a little bit instead of bending backwards. Why? Because the segment's injured and unstable, so that it's going to be wobbling. It hasn't restored its stability. So doing some of those backward bending movements can be problematic. So we do have some advice, I think, in the membership group about some modifications that you can make to the Cobra to tweak it, where you put a bit of more of an elongated pull. But there's better exercises like the towel that we'll talk about later to do that and be more helpful. So that's probably the best one out of these in terms of the Cobra. The others, just leave them because they are fundamentally making things worse. So Then we get into the strengthening side of things. Now, strengthening is really important. If you're doing any sort of strengthening work, that's really going to be a great thing for you because it's going to be building something that lasts, building something that was maybe missing before, building stability to protect that area. With the back and shape program, we talk a lot about building that suit of armor to protect the lower back discs while they're trying to go through that recovery and remodeling process. And that's going to protect them while they start to rebuild. And then we can start adding load, et cetera, going forwards over the long term to guide that remodeling and healing process in the discs so they get strong again. Remember, the whole spine is very, very strong. Once we've got that injured segment, it's significantly weaker than everything else. We have to spend time rebuilding it back up. So we've got exercises like the bridge. We've got the Superman. Two very common ones. And I'll break off at those first and foremost and talk about those because there's some issues with those. The bridge, not that it's a problem because it's off weight bearing, but the bridge, because it's both legs coming up, one of the common errors that people make is as they drive up through the hips, they actually extend the lower back, which brings us straight back to the Cobra comment, and we're going to arch that lower back, and that can sometimes be problematic and aggravatory. It's not a massive issue, but it is something that can be problematic. And that's why we recommend, in many cases, the marching bridge instead. Because the marching bridge, you get up into that position, you can monitor keep a neutral spine and don't arch, and then you can deal with the transmission of weight from one leg onto the other and then back again, which is going to help you with your core stability as you're shifting from one limb to the other, which is like walking, for example, or moving around in life. Many of the challenges, the flare-ups that happen for no apparent reason are because you've shifted your weight from one side over to the other and your core hasn't done a good job of holding everything square at the same time. So something like a marching bridge instead of a regular bridge is going to build that factor, that control, that skill, which is going to be applied later on in upright exercises. Just doing the bridge as well, it's not really going to build much strength because chances are, like most people, and this is really important for strengthening side of things, most people get stuck doing these silly floor exercises. And I say that rather flippantly because it's true. Most of you watching this, and the amount of times I've done a phone call where someone said, I'm really in a lot of pain, I can't do anything, and they get up and down out of their chair like 15 times while we're on the call, obvious reasons, because the back hurts. But I'm there like, you're doing a squat, like 15 times while we've done this, yet you're worried about doing squats. Why is that? It doesn't make any sense. And the notion that you can lift your whole body weight out of a chair and you're willing to do that on a daily basis, how many times you sat down, you maybe even sat down on your chair while you're watching this episode, yet you think, oh, I couldn't do that. Well, if you're already doing a squat, you're probably putting more strain on the muscles than doing a bridge, and therefore the bridge is not going to reach significant thresholds to elicit strengthening or make strengthening take place in your leg muscles, in your glutes. So therefore, it's kind of a pointless exercise. The same goes true to the Supermans. Many of you, again, will be doing movements, even though you're in pain, around the house daily, which involve the load of gravity. Lying on your front and going like that into that position, yes, it activates the muscles, yes, it uses the muscles, but it's not really challenging them to build any significant strength over the long term. Instead, working with exercises like hip hinge, which we'll talk about later, are going to actually allow you to build strength in that region. Additionally, hip hinge, in contrast to the Superman, is not about extension again. We don't want in these early stages of recovery to be going into a position or another. We want to focus on building back that neutral. It is the failure to control neutral that leads to these injuries. We get pulled off in one direction or other. So early stage exercises need to focus on the neutral. And that brings us to sort of the back end exercises of these, which are a little bit more perhaps appropriate. Now, I say that right as I'm going through the plank, the straight plank, which I don't really like. The reason for that, similar to leg raises, is that when you're in that position, yes, you're working the core, yes, you're working from a stability point of view, but it's all too easy for our hips to drop in and to arch our lower back, which is a problem. But also we put maximal compression through the L5-S1 disc and to a lesser degree the L4-5 disc, which in the early stages of recovery, that just isn't going to be ideal because you're squashing through that disc. As you squash through that disc, it drives the disc through the weakest point, which is going to be those injured ligament layers of the annulus. So we want to leave that out ideally so we don't create more aggravation. Instead, we find that a side plank on the knees in the early stages works an awful lot better. It doesn't quite have the same degree of aggravation or focus through that L5 disc, and it can be more effective at training us to deal with the lateral stabilization through our trunk region, which is really important. Again, thinking about shifting weight from one leg to the other, real world movements, real world aggravations that take place, thinking, oh, I flared my herniated disc up yesterday and I didn't even leave the house. I was just doing some posturing around. I was really careful. But it's those little movements as we shift from one position to another that are lateral movements, not square on going straight down, that really challenge us. So working on a side plank instead of the straight plank is going to be better and arguably less risky from that point of view. One little note with side planks is that sometimes when we're doing the pulse, if we do have that disc material bulging out to the one side, it can mean that as we close the hole ever so slightly on the one side, it can be aggravated. So you need to kind of work around that and not aggravate yourself unnecessarily. That's where you're kind of listening to your body and what's happening when you're doing the exercise. And the final one, which is one of the ones where we say this is actually a good one, is going to be that bird dog. We just prefer to do a dead bug personally. I find it better. I find it easier to manage and maintain the lordosis, and we've got extra tips to help you guys do that more effectively without losing the lordosis and have better feedback of your body whilst you're doing the exercise. So a modified dead bug that we teach would be a better option. But the bird dog is actually the first one where you're actually learning to stabilize the spine as something is moving and pulling the spine in different directions. And we'll come back to that a little bit later on. But before we do, we'll kind of jump into just one more topic about the loading side of things. Those are the classic exercises that we've just discussed from a strengthening point of view, but they're really missing a major factor, and that is the ability to add load to them, the ability to add resilience over time. The simple fact is most of those are all off weight bearing, which means you're not even dealing with the weight of your torso, let alone the reality that you've got a little one that might weigh 15 kilos, might weigh 10 kilos that you're going to pick up. You've got suitcases, you've got shopping. You need to have, as part of your rehabilitation, strengthening load-based exercises. And those are what help drive the recovery and resilience restoration part of your rehabilitation process. Too many times people get stuck doing these exercises that we've just discussed over time, and they don't actually progress on. They need to do that because you're not going to build resilience to your lower back if you don't add load. Now, before we get into the exercises that we recommend, just one last thing that's commonly recommended when it comes to exercises for herniated discs, when it comes to the recommendations of activities for herniated disc, and that is low impact exercise or activities. Great. It's important to keep your cardiovascular system up. It's important to get some movement going on because it is little amounts of movement that actually really helps with the drainage process, the getting rid of excess inflammation, because we discussed earlier how that's so important that we don't allow that to run away with itself, because that's going to create real problems. So one of the common exercises or activities is going to be walking. But you'll see, like in some of the examples that we've used here, walking is recommended. Do 30 minutes, do longer. No, walking has limited use. Yes, walking is great. 5, 10 minutes, sometimes even 5 minutes is difficult. And then where it's really difficult to do walking, we have to do our best to try and do it within tolerable amounts. It doesn't create too much of a flare up, and do that in conjunction with other relief-based exercises that we talk about, like the towel, which we'll get onto. And icing, etc., to help calm things down in the very early days. But just walking, as we discussed in a dedicated episode of the podcast on walking, is not the answer, primarily because it's not building anything, and it's taking away from time that could be spent doing more fruitful rehabilitative exercises that are going to be helpful for you. And it's all too easy certain times of the year to go, I'm able to walk now, I'll just keep walking, and because I like it, I'll walk the dog, I'll do this, that, the other, but it's not actually rehabilitating you. And all too often, as we start to feel better, we just start doing more and more walking, thinking it's helping us, and it's not. The next one is going to be swimming. Swimming is a great exercise because it takes the weight off your body. But I often find that the time that you need this most is going to be when you're really, really vulnerable. Just that ability to be in the water and take pressure off your spine is so great. And we can move around a little bit. We can get rid of some of the excess inflammation. It feels really nice. The big problem is going to the swimming pool involves contorting yourself, getting undressed, getting dressed again, walking around a slippery surface, which is all too easy to slip, and that's going to be a big problem for you. And then we've got those tiny cubicles that you're getting changed in. The process of doing the swimming negates the benefit that you're going to get from the swimming, fundamentally. And once we get to later stages of recovery where we need to build resilience, swimming might be good for fitness, but it's taking away from time we could be spent load bearing. And it is the load that becomes so important. Careful addition of load, sensible addition of load with good form, that is so important in the medium to late stages of your recovery and rehabilitation. And that really, that short phase of being in excruciating pain where you can't do much is generally a short-lived period. Then we get into the period where we go back to work, we start doing many different activities, again, of daily living, hobbies, etc., and we're still in pain. But that's where, and then we get to the period where we're not in pain. Those are the two periods where much of the strengthening work needs to take place. And so often, because the pain levels come down and we can do these things, we go away from them. And if you're a swimmer, perhaps, and you enjoy doing swimming for cardio, it's so easy to just go, I'll go back in the pool and I'll start doing swimming because that's helping my back. It's not helping your back. It might be good for your cardio, but it's not rehabilitating your back, and you'll be left with a degree of vulnerability in the lower back. And that's why things come back over and over again. And then we have cycling. I really don't know why people recommend cycling. As I said earlier, the average adult spends 9.5 hours a day sitting down in a chair. You do not need to do your rehab sitting down in a chair. It doesn't do much for moving the spine, so it's not got the same benefits of the walking. It's just sitting down for extended periods. And sure, it's got some cardiovascular benefit, but choose walking instead, or get on a cross trainer or something like that. We went in detail very recently, so I won't bore you with more detail now, into why cycling is a problem. For those of you that are competitive cyclists and you really enjoy doing that for hobby, in that episode of the podcast, we have some workarounds, some strategies. But for the average person that's just been told you should do cycling because it's low impact, ignore that. Do walking instead, or on a cross trainer, and follow some of the other advice that we talk about here and other episodes of the podcast. And obviously, we do have the Back in Shape program that can help you go through that effectively. So that brings me to the last part. Hopefully, this has been insightful for you, and now hopefully it's going to be a little bit more helpful. The exact strategies that we talk about. So number one, from a relief point of view, immediately, the towel stretch. This is by far the best stretch you can possibly do. Although it might be uncomfortable for some of you who have significant degenerative change, perhaps in the discs, or have significant disc bulges. The towel stretch is a stretch that puts your spine in the most neutral possible position. It's free for every single one of us to do. We all have a towel at home. We can roll it up and lie over it. Bigger is not better. Don't use a foam roller. Just use a normal towel. It's gentle. Okay, you place it in the lordosis, and we have many videos on the towel stretch, and again a dedicated podcast on the towel stretch if you're interested. What is this doing? It's putting a gentle stretch through the discs. It's taking them off load bearing. It's not squashing them down. It's also orientating the spine correctly, holding it in its braced position. Just like, for example, after we've sprained an ankle or broken an arm or broken a wrist or something like that, we want to hold it in its neutral so it can get back into that position and shore up in that position before we start throwing other bits and pieces in. Obviously, that's time dependent depending on the injury that we've got. It also takes pressure off the muscles and the ligaments on the back part of the spine. Those muscles are often tight and tense, and we think they need more stretching, but they don't. They just need to be taken off pressure. And that's what the towel does. Very, very good one. It's good in the short term when you're in real trouble at taking pressure off the injury, but it's also a good antidote to the stresses and strains of daily life as they build up through, again, the repetitive sitting, like you're probably doing while you're sat down now with a little bit of a round through the lower back. It's going to take that pressure off. It's a really, really good one and super easy to do, accessible to everyone. Then we go to the next level, which is the core engagement. That's learning to correctly engage your core, your transverse abdominis, the other core muscles, the obliques, whilst you are in a neutral position, and not having to hook that to something like a pelvic tuck. Learning to stabilize your spine lying down on the bed or on the floor is going to be the best skill you can learn early on, because that's going to translate to more effectiveness, more safety later on when you start doing load and other exercises. Once you've learned that, we can move on to exercises like we mentioned, the dead bug, lying on your back in the same position and starting to move one leg or the other. Why are these good? Because we're focusing on maintaining spinal stability and stopping the spine from moving. Remember, when the spine moves, that's when it got injured. When the spine got extra compression coming through it, that's when it got injured. When it twisted and bended, that's when it got injured. So we're working on maintaining, or that's when it got flared up, as is more commonly the case once you have that initial injury. It's when it got flared up, moving around the house, loading the dishwasher. It was the movement that aggravated things. So we're now holding the spine in a neutral position, moving one leg or the other. And that's going to create a little bit of bending. It's going to create a little bit of twisting. It's going to create a little bit of extension or flexion. It's going to create the propensity for those things to happen if you do not control the spine. So we're not doing those movements, but those are the movements that will try to take place in the spine. And you're then using your core stability to stop those things from happening. That's building resilience, because then we take your body and we put it upright, and now we start to build from there. We use two main movements, and there's more to this. We go on with the detail in the program, but then we start to add movements. The two movements: washing your face and getting off the toilet. I say that rather tongue-in-cheek, but I mean it, because if I say that, then you do that every day. You wash your teeth before you go to bed, and you probably get off the toilet once or twice a day. Maybe more, maybe less. That's something for another topic. But the point being, you do a squat and you do a hip hinge. Those two movements are vital for effective movement around your daily life. You are doing those every day, so they should be part of your early rehabilitation process. Even if you're going to be rushed into surgery, or not rushed into surgery, but even if you're going to be told you need surgery next week or the week after, I guarantee you your surgeon told you to get in the car, which involved sitting down, probably in an awkward position, and then get out of the car and then come to see them and then sit down in their chair and then get out of their chair. How many squats have you done? And they knew you had a herniated disc, but they were willing to tell you to do those movements. Why? Because we can't avoid them. So you better learn to do them correctly. And that's where that's where instruction, that's where technical skill, and that's where the guidance can really help you make sure you're doing those effectively, because inappropriate skills in the things that we've just mentioned through this little last part of the podcast are fundamentally the reason why your herniated disc doesn't get better. You're lacking those. And so many of you, unfortunately, fall into the habit of focusing on all the other exercises that we've mentioned today in the podcast, instead of working on those core fundamentals. And then obviously comes the kicker at the end, is you've got to then start to add load conservatively back in over a long period of time to rebuild the strength and resilience of that disc and the segment at large so that it can reorientate itself into what is, in all of us, a strong spinal structure that is both mobile, but also has the ability to load bear without feeling fragile all the time. Unfortunately, we don't take care of our backs over the years until we have a problem, like so many things. And like the recovery process, many of you maybe even had this experience where you feel like, oh, the herniated disc has gone away. And then so you're doing back all those other things. It hadn't gone away. It just went away up here. It was still trying to heal, and you stopped doing all the things that were necessary to help continue that healing process. And then it gets re-aggravated. We must continue to do our load-bearing work and progressively build that over time so that we get real results when it comes to fixing these herniated discs and allowing our body to adapt, accommodate for that damage, and heal effectively. It does take time, but you can do it if you start doing the right things and cut out some of those waste of time exercises that are often holding you back and making you worse. Do the right things, we'll get results. I know it's been a long one. Just looking at the clock here, that's 40 minutes. I think that's probably a record for the podcast. So I do apologize. Thank you so much for staying with me. I do hope it's been really helpful for you. And the article is equally as long, around about 5,000 words, but hopefully the detail there is really helpful for you to really understand once and for all these exercises, why some of them are good, why some of them are bad, and precisely why the ones we talk about are better and what they're actually doing. Again, if you've got any questions, use that comment section underneath. If you did find this video helpful, consider subscribing to the channel and the podcast so you stay up to date with every week when we release the podcast. And if you know someone else who's been struggling with their back pain, their herniated disc, whatever the case may be, consider sharing this with them. We really appreciate you guys sharing the podcast. It means a lot to us. And yeah, I think that's pretty much it. Thanks for watching. We'll see you in the next episode.